You've probably heard of human trafficking, but what if I told you that there may be a child experiencing trafficking sitting in your waiting room right now? When we think of trafficking, from forced labor to sexual exploitation, many times we think of what we see in the movies, but that's not what's happening in real life. And pediatricians are often the first trusted adult that a child may encounter when they're experiencing exploitation. My name is Dr. Dana Kaplan, and I'm one of the co-authors of the new policy statement from the AAP on human trafficking and exploitation in children and adolescents. Today, we're going to walk through the guidance provided in this policy statement. The big takeaway is twofold. Number one, we really need to approach this population with a trauma-informed lens that is patient-centered and rights-based. That's number one. Number two, we as pediatricians are in a unique position to advocate for this population, for resources, and for further research in specific areas that perhaps aren't researched enough. Many people, when they think of trafficking, think of it as a global phenomenon, an international phenomenon. But trafficking happens right here within the borders of the country in which we're living, within the United States. And trafficking doesn't always imply movement. You do not have to leave the apartment where the trafficking is occurring. You do not have to leave the sidewalk. You do not have to leave the state. You do not have to leave the country. And it's something that we should all be aware of. And it takes different shapes. It takes different forms. It doesn't always look the same. And it certainly doesn't look like what we see in the movies. For example, the movie Taken. That's generally not what we see here. And if you're looking for that, you're going to miss this population. When it comes to identification, really the only way to identify someone is when they disclose. And that we know is difficult. I'm a child abuse pediatrician, and we know that disclosure is a process. It happens over time. So you may be seeing a patient where you have suspicions, but they're not ready to disclose, or they may not even conceive of what's happening to them as exploitation or trafficking. If I'm seeing a patient where the history, the clinical history they're providing isn't matching with what I'm seeing in front of me, much like we see in children who have been abused, it just makes me stop and pause and take a breath and think, okay, what else could be going on for this individual? Because many times a lot of the signs are related. So all forms of interpersonal violence may present with mental health concerns, may present with being part of a vulnerable population, such as the LGBTQIA plus population, such as homeless youth, such as undocumented youth. So those are groups that are at high vulnerability for interpersonal violence, human trafficking and exploitation being one of them. I think sometimes pediatricians or healthcare professionals in general get so sidetracked by their worries about a patient. A patient comes in and you see something that brings about concerning features, a patient who's been to see you multiple times for a sexually transmitted infection, a patient who might have marks or bruises, a patient who has new tattoos that they don't want to talk about. And we get so sidetracked by those concerns because we are the helpers that we forget about why they came to see us in the first place. And if a patient doesn't feel heard, then they're not going to disclose, and they're definitely not going to come back to see us again. So we have to put our agenda aside, and we really have to refocus on the patient. Why is the patient coming to see me today? Are they coming because they have a sore throat? Well, address the sore throat. Are they coming because they have a UTI, a urinary tract infection? Address that. Listen to them. Take them seriously. Are they hungry? Are they coming because they need food? We see that oftentimes too. Give them food. And then if you have the opportunity, before delving into exploitation and interpersonal violence, you have to gain rapport, right? These are sensitive subjects. If we think about ourselves going to the doctor, right, it's really difficult to just dive into these really personal issues, not to mention that the patient might not, again, conceive that what they're experiencing is this or is in this bin. So we have to be very gentle in our approach. And when we're given an answer, sometimes we have to accept it. So, for example, if a patient comes in with a urinary tract infection, that might be a good time to talk about sex. Are you having sex? What kind of sex are you having? Is it sex that you want to have? Is it sex that you don't want to have? And if that person seems receptive to talking about sex, then maybe then you can bring up things like sexual exploitation, online exploitation, if you're given the opportunity. But if a patient shuts down and immediately says, nope, that's not happening for me, and I don't want to talk about it, we must respect them and we must respect their boundaries because these are individuals whose boundaries have been pushed. The narrative is not necessary to put in the medical record for a routine visit. I think that showing that you have concerns for interpersonal violence in your notes so that hopefully if the patient comes back, you remember to address that again. And I think that's a key part for all pediatricians is a 15-minute visit is not going to get you all of the information about a human being, right? We can all appreciate that. It's the follow-up. It's the coming back. It's the trust that will eventually perhaps let the story unfold if there is one. So it's really about being able to put information in the medical record that reminds us, okay, I want to readdress this again. I want to follow up with this person and see how they're doing and see if they're in a space where they would like to discuss more about what they're experiencing in their personal life. For those pediatricians that would like to learn more about this population, there are local training resources specifically geared for the human trafficking of children and adolescents. There's not enough resources. That's something that we all need to advocate for. But what I would recommend is really gaining traction with how to provide trauma-informed care. That is the start and finish to all patient interactions. And the AAP and many other organizations are really providing a lot of resources and education in that space, which I think is great. So take advantage of it. Once you understand trauma-informed care, then you can truly start to advocate for your patients on a local, on a state, national, or international level. It should be no shock that lots of the exploitation or the grooming that we see coming with exploitation begins on the internet. It begins online. And so we recognize that online exploitation and online sexual abuse materials are becoming increasingly problematic. To address that, the American Academy of Pediatrics will be putting forth a policy statement and a clinical report. I am a co-author, so there's more to come on that. Pediatricians are uniquely positioned to recognize and respond to children who may be experiencing trafficking and exploitation. This policy statement gives you the tools to do that, grounded in trauma-informed care and an equity-based approach. To read the full statement and access all clinical resources, please visit aap.org. Thank you all for listening.